pleasure to be with you, and thank you very much for the opportunity to talk with you all today. Sound okay? Everybody getting back right? My family is actually from Madisonville, Texas, so I always love to come to Texas. I feel like I'm coming home. I was raised in New Mexico, but Texas is a great state. There's a taxi driver over here. I always ask taxi drivers how are things doing, and they almost always say, oh, business is really terrible. First time, taxi driver said, business is great. And I'm thinking, I love Texas. You guys are the exception to the rule. So what we're going to talk about today is health reform, what's next. And what I'd like to do is kind of give you an overview of where we are. And I wrote a book called Why Obamacare is Wrong for America, so full disclosure. I'm very concerned about this law. I think Jason did a very good job this morning of talking with you about what's coming and all of the rules and regulations and the incredible complexity of this law. And it is my conviction that there is huge opportunity and there are a number of ideas and resources in the health sector to get us back on the right track. But in order to do that, we have to step back so that we're not spending all of our time and energy complying with a law that really does centralize power and control in Washington and not in the marketplace with consumers. So just a few pictures here. This is the Supreme Court as it usually looks, and this is the way it looked the day that the Supreme Court began its oral arguments on the challenge to the health law. I'm going to call it Obamacare. The president says that's fine with him. Obamacare, so he says. So you can see this is something that really did energize the American people. This is, folks, we love Obamacare. There were just as many people up there supporting the law as there were people opposing it. I'm there speaking. The Tea Party Patriots had a podium. Everybody's sort of funneled through. So I had my say. I don't know if it's possible to turn on just these lights so that the screen shows. Can y'all see it okay or not really very well? And then here's this guy. I thought this was really interesting. He's over on there were two podiums. There was a podium put up by the Families USA, which is very supportive of the law, and the Tea Party Patriots had another podium, sort of people who were opposing it. Oh, great, thank you. But here's the guy had his podium, his sign over by the Families USA, strike down, single payer now, strike down the Obama mandate. I thought, let's have a policy conversation. I think they're a little confused here. And so here were the lawyers and others who were inside the Supreme Court. Limited seating, so I thought it was more interesting to be outside and inside listening to the oral arguments because they released the tape almost immediately afterwards. And then this is the Supreme Court as the decision was being released on the 27th of June. So you can see just as many people, just as much activity, just as much passion. Obamacare makes me sick. And of course the Supreme Court decision did confuse people. And this is the result. People, 45% of Americans either don't know that the law was, that the Supreme Court did not strike down the law, or they either don't know or they think the Supreme Court did strike it down. Only 55% of Americans know that the law still stands. And yet this is a law that's going to affect every single one of us. So I think this is something of a concern. By the way, when people say the Supreme Court upheld Obamacare, no. There were two provisions being challenged. The individual mandate, and all of us have to purchase government-approved health insurance, and also the expansion of Medicaid, the mandatory expansion of Medicaid to the states. So the Supreme Court said, well, we're going to uphold the individual mandate, but not under the Commerce Clause, which allows the federal government to basically regulate commerce among all the states. We're going to uphold it as a taxing power. And with the Medicaid mandate, they said it's too coercive to say say that states have to lose all of their Medicaid funding if they don't expand Medicaid up to 133% of poverty. That's now optional for the states. So basically, Chief Justice Roberts rewrote the law because that's not what the law said. And he was really a majority of one because no 4 other justices agreed with him on all those provisions. There are a lot of other challenges coming through the courts to the law, including the Catholic Church that's challenging the preventive care mandate that says that employers, Catholic charities, Catholic hospitals have to provide abortion drugs, contraceptives, and sterilization procedures, even if they fundamentally say that violates our religious beliefs. So there are a lot of other challenges making their way through the courts when we talk about this. So it's understandable the American people are confused. And I think the real shame is that the American people agreed in the beginning that we need health reform. And what we needed to do, we need to make coverage more affordable. Lisa, in the earlier workout, in the last breakout session, had a slide showing what is the concern of employers. What's the concern? Cost. It costs too much. We want to make sure that we keep the best healthcare system in the country. And we want to expand access. We don't want it that 50 million people don't have health insurance. Fix it. We need to get that done. Most people rate the coverage they have now as good to excellent. And they want us to fix the problem for everybody else, but don't change it for us. And what people now see with this law is that this is a Gallup poll taken the middle of July. Americans say it will make things worse rather than better for taxpayers, for businesses, doctors, and for those who currently have health insurance. So if you wonder, why are the American people so continually opposed to this? It's because we didn't get it right. That Rube Goldberg slide that he had, maybe I should have given you a little more specific detail. This law is too complex. And 82% of Americans say that health care is going to be an important consideration with their vote in November. Now, for some, it's going to be making sure that the law stays in place. For others, it's the final opportunity to say, this is not what we wanted. This is not the law we wanted. We want to fix it, but not this way. And as a result, opposition is higher now than it was before the law passed. Did you say this? I have a few copies of this, actually, hard copies. This is not a cartoon. This is actually a serious effort by the Joint Economic Committee staff of Congress to map the law, the 159 new boards, commissions, and agencies, how they interact with each other, who has new powers under this. You can see underneath here, I don't know if there's a way to take this podium off. I know that it's blocking what you all can see over there. But there are rationing potential, new mandates, taxes, and mandates. Can we just put that on the floor? Just move it forward. That'd be great. Thank you so much. I thought of that earlier. But you don't want to miss this. Thank you very much. This is, and they only could get a third of it, by the way. Couldn't do it all. They ran out of A, time, and B, you couldn't even read it. So it's a serious effort, and you can see that the power is respective to the size of the circles. Look where the real power center is. More than 2,000 times in this law. The secretary shall, the secretary must, the secretary has the authority to. She's really got enormous power over 1/6 of our economy. And when you drill down, actually you won't want to miss this, laser pointer. So look where physicians are, way down in the corner, bottom even drill down to a whole nother level of complexity. This is a map of the small business tax credit and what an employer that has fewer than 50 employees and average wages of less than $25,000 a year is eligible for the tax credit. It has been, the uptake, shall we say, has not been overwhelming. So what we hear, though, about this law is the early provisions, the free preventive care, allowing children on their parents' policies, pre-existing conditions, seniors help with their drug costs. A lot of people really think that's really what the law is. What was the big fuss about? Why were people calling Congress 100,000 calls an hour when this was leading up to passage, saying, please don't vote for this, most of them? And it's because it's really a much bigger deal than this. This is my good friend Ovik Roy with the Manhattan Institute, sort of was able to get Obamacare into one slide. So basically you look at the spending authority. It's this Medicaid expansion. States still have the authority to expand Medicaid, but it's now optional. And then huge subsidies, and we'll talk about them in a minute, for subsidized private insurance through the exchanges. And it's paid for through $716 billion in cuts to Medicare and through lots of new tax increases, $1.3 trillion over 10 years in new tax increases. And by the way, if anybody wants a copy of this, I think we're going to, Doug, you're going to put it on their webpage, but I'll also be happy to send you a copy if you want to get in your card afterwards if you need it, send me your map. And so, you know, when the cartoonists start to get it, I think, okay, good. They understand it. So here's Professor Obama talking about mandates, penalties, taxes, fees, and the poor consumer, and say, where does it say I pay less for health care? How on earth with 159 new bureaus and agencies and commissions, and that's just the federal level, do we really think health care is going to cost less? 2.6 trillion, it hasn't even started yet. And this is the progression of cost estimates from the Congressional Budget Office about the cost of this law. We're now up to 2.6 trillion. And that's because, even though most of the provisions haven't gone into effect, remember they did 10 years of tax increases with only 6 years of spending. Well, we're further along toward the 10 years of spending, and that's really what's showing up here. And that's going to continue to go up. And so here's another cartoon. So here's a bleary-eyed Uncle Sam. Obamacare adds coverage, lowers costs, the fine print. Doesn't actually lower costs. May cause seniors to lose Medicare coverage. Side effects include nausea, rapid heartbeat, sweaty palms, headaches, pain, feelings, fearing anxiety, bulging eyeballs, a lightness of the wallet area. If conditions persist for more than 10 years, consult your physician. If your physician is still your physician, then you can actually get in. So, the fine print. So, where are we? I think Jason talked with you a little bit about this earlier, about the penalties. $2,000 per year for employees if you're not providing coverage that meets federal specifications, and $3,000 if any of those employees go into these new exchanges. And since Governor Perry has said he's not going to create an exchange, it creates an interesting dynamic of whether or not then your employers, you and other employers, may actually be protected from these $3,000 penalties. Because if there's no exchange for somebody to go to, then it's hard to see how the subsidies or the penalties are going to be triggered. And actually the state of Oklahoma has amended its original challenge to Obamacare to focus on this issue. So we'll be following that. My colleague Tom Miller from the American Enterprise Institute is leading that. And then if an employer offers employee only coverage that's affordable to the worker, family members are not eligible for coverage in the exchanges. So somebody who's working in order to provide benefits for the family, but at a lower income, may find that they can get coverage through the employer, but the family's not eligible for subsidies. So there are lots of complexities, and I'll be happy in questions to talk a little bit more about that. There is a lot of talk in the employer community that maybe not offering coverage could be the best thing for their employees. And the reason is the subsidies in the exchanges are so incredibly generous. A person earning $42,000 a year with a family qualifies for almost $15,000 a year in subsidies through the exchanges. Single person, more than $5,000. But that's only if the employer is not offering coverage that is, to say this in the right way, I always get this backwards. The coverage has to cost no more, the employee's share of the coverage has to cost no more than 9.5% of their income in order to be able to have coverage through you. Otherwise, they can go to the exchanges and get these really heavily subsidized premiums. That's why this is costing $2.6 trillion. To put this in a larger context of federal budget issues, Medicare is also a huge driver of the deficit problem. And we hear a lot about people saying, well, I paid for my Medicare. They can't change it. They can't take it away. A typical couple that retires today worked their whole lives, average income, would have paid about $119,000 over their working lives in Medicare taxes. Those are FICA taxes you see in your payroll sector. But they're expected to consume almost $357,000 worth of health benefits over their retirement years. So this red gap, the $238,000 for just two people, is the difference between what they've paid in, and of course that money's already been spent on yesterday's retirees, and what they're expected to consume. So when we talk about Medicare reform, I think this is a really clear way of understanding why, if we are going to not have to tax the next generation into oblivion to pay for all these health benefits, why we've got to begin to look at Medicare reform. 10,000 baby boomers age into Medicare every day. And that's going to happen for the next 20 years on average. So do the math. This is why we have such a huge problem. And then, this is probably something y'all can really relate to. This is a slide that really gets the physicians going. Any physicians? Doctors? Is there a doctor now? This is the growth of physician administrators as opposed over time from 1970 to 2009. This little small red band across the bottom is the number of new physicians. The big pink mountain is the number of new administrators. 3,000 times more administrators over the last 40 years. And that's before Obamacare. This is where a lot of the money is going. Hospitals. Physicians are selling their hospitals, their practices to hospitals because they don't know how they're going to comply with all of these new rules and regulations. So what's going to happen? What's going to happen with the legislation depends on what happens with the elections. People think, well, there's no way. I mean, if Mitt Romney were elected president, recently every single one of his speeches, they got this big banner in the back, repeal Obamacare, so you know what you're getting. With the Senate, if Republicans were to take 51 votes, they could undo a great deal of this legislation in the same way it was passed. Remember, when Scott Brown was elected, they had to figure out a way to get around the fact they no longer had 60 votes in the Senate. They passed a lot of this law through reconciliation. That's also a way to undo a lot of it. So I think we're going to continue to see a debate over this law if the dynamics in political control change. Regulations, we already have 13,000 pages, not even begun. When Medicare was passed in 1965, the law was 135 pages long. The Mayo Clinic did a survey a few years ago, and they found that the number of pages of Medicare regulation they had to comply with 40 years later was over 100,000 pages. That's what we're seeing. And as I mentioned, lots of other court challenges. But the voters really are ultimately going to make the decision about what happens with this law. And let's talk about, okay, well, let's say we are going to track to repeal. What are we going to do instead? And I actually think these are the forces that are going to propel us in any case, because the law is going to have to be changed. I did a speech in Paris not long after the law passed in 2010. And I was invited to speak to something called the European Congress of Private Hospitals. And I'm thinking 20 people, right? Room at least this big, hundreds of people, 5 translation booths in the back of the room. It was amazing. A 4 or 5 day conference. There's enormous energy to realize in Europe where they realize centralized government control doesn't work. Consumers have too many demands. We've got to figure out how to move power of control back to doctors and patients. They look at private enterprise and competition. It's the only way they're going to save their government-controlled systems. And they want to figure out how to decentralize decision-making. And I'm thinking, the world's upside down here. Here we've gone completely the other opposite direction. And here in Europe, which, by the way, did you see today, the European Union won the Nobel Peace Prize. Somebody said they gave a prize to themselves. So what do we know for sure? The American people want choice. They want to be able to make sure they get the best health care in the country, in the world, that they continue to have innovative health care delivery systems as well as medical care. Diversity of choice are essential to accommodate the needs of 300 million Americans. Focus on the patient. They want doctors and patients, not government, to be making these decisions. And then we want to help people find value in their healthcare spending. It doesn't mean the cheapest coverage. That means the same kind of decisions that they make overall. And unless we begin to move in the direction of allowing this individual control, the promise of personalized medicine could well be probably not lost, but significantly delayed, where treatments in cancer treatments can be tailored to our own particular genetic makeup. So we know before we get these toxic doses whether or not it's going to work. But that requires focus on the patient, not sort of the generalized, well, this is what works in the population as a whole. We've got to do this. And in order to do that, we need to focus on engaging patients as partners in managing their healthcare costs and getting the best value for their healthcare dollars. A lot has to change to make this happen. But this really is the vision. And it comports with how the rest of the economy works and what people ultimately want. Healthcare is lagging, but we can get there. So what are some of the market-based solutions? Defined contribution is sort of the umbrella overall theory. How do we give people more control? We give them more control over their spending, over their purchasing. This is true whether we're talking about Medicare, Medicaid, private insurance, restructuring the financing so that people are more in charge of control of choices. So that if you're on, this is what the idea of Medicare premium support is. A quarter of seniors have already selected Medicare Advantage plans. Yes, they've got to redo the financing, but they get it, that private plans that are coordinating their care, that have their medical records, can give them better care than going to a bunch of different physicians who aren't talking to each other. Medicaid. Medicaid is a terrible program. It's a ghetto of a program. The health outcomes of people on Medicaid are very little different from people who are uninsured. They have to go to hospital emergency rooms to find a physician to see them often because it's so difficult for private physicians to take many Medicaid patients with the low payment rates they get. And with private insurance, a number of companies are looking toward defined contribution. How can I make sure my employees continue to get health coverage, but I can control my costs? So I'm going to say, right now, we're spending $12,000 a year for your health insurance. This is on average for a family. And you're putting in $3,000 or $4,000. Same deal. The numbers will increase, but probably with inflation, a smaller level every year. And we're going to give you a range of choices to pick from. Jason said that his company is talking about setting up private exchanges. I expect to see a lot of that, where people can go into a marketplace, not just saying, here's the money, you're on your own. Here's an organized marketplace of places we know are offering good coverage. That's how the members of Congress get their coverage. And that's what people want. But to do it, we need to change the financing system. So some of the common themes I think you're going to start to hear about. How do we engender personal responsibility? You do it by giving people a stake so that they can see. If I call the nurse hotline, instead of going to the emergency room, maybe I won't deplete my health savings account. Maybe I'll save some money. Make sure that people are getting the right care, but getting it in a setting that is appropriate to the expense. Much better coordination of care, as I mentioned, is important so that people are not getting 3 different CAT scans because they're going to 3 different specialists, so that somebody is really in charge of making sure that you're getting the right care and that those results are being shared. Incentives for patient participation, we talked about that during the wellness session earlier. Doctors, not bureaucrats, making decisions. People are very worried, as they should be, about this new independent payment advisory board in Medicare that's going to have the authority to 15 people making decisions about what benefits are going to ultimately be available by how much is being paid for Medicare services. That's not what people want. So the states, I think, also have an important role. And here in the Chamber of Commerce, I think we can really help to facilitate that. Association health plans or their versions, so that people can purchase health insurance through your organization. That therefore can be more portable. If they move from one job to another, they don't have to lose their health insurance. That also helps with pre-existing condition problems because they haven't lost their health insurance at arbitrary time. We need a better safety net for high-risk people. There always are going to be some people who are just not insurable. We want to take care of them, but we need to do it in a way that the states, knowing their resources and knowing their constituencies and the systems that they have, can be able to provide those options. If we would have taken the $5 billion, creating this new federal high-risk pool system, and let the states have that money, we now would have many more functional high-risk pools rather than this duplicative system and one that's going to expire in a year and a half. More competition among providers and among plans and maybe even among physicians can allow people more choices. And then I do still think that people will value the role of employers in helping them organize their health coverage. We have, almost 60 years of history in this country of people getting their health insurance through their employer. I think you're going to continue to play an important role. But for a lot of people, that's not working. And so we need to make sure that they're not only the safety net program, but people have other options for purchasing coverage. Just as one example of why I think this that's tied and will continue to move forward. This is the uptake of health savings accounts, the health insurance that people purchase in order to be able to have make the tax-free deposits. Look at this. We're now up to about 13.5 million people that voluntarily, once again, have moved to health savings accounts. They want to pay less for insurance, higher deductible, make sure they're covered if anything happens. But they want to put the savings from that insurance into an account that they own. They can take with them, becomes their own personal savings account. Pay your premiums if you lose your job. Pay that deductible if you do have a major experience, medical experience. And so when we talk about consumer-directed healthcare, there's really a lot of different things. It's not one solution, and the marketplace is really going to determine, I think, even more choices than we see now. A constellation of offerings that give people more power and control over their decisions. Health savings account, health reimbursement arrangements, new chronic care management programs that incentivize patients to do the right thing. If you go to see the pharmacist, you'll get your diabetes medicines for free, for example, the Asheville Project. New consumer-focused clinics, MediClinics, ReadyClinics that allow people to go to the options instead of the hospital emergency room to get care in off hours. And then a lot of information support tools so that people can make the decisions on how to best spend their money. We're not there yet, but that's the direction the health sector is moving, and it's the direction I think people really want. So if we move toward these consumer-directed plans, I think we can help to realign the incentives so that states, employers, consumers, all can save money while boosting prevention and wellness because they've got a stake in the outcome. I have another slide that I should have put in here that showed that people in these high deductible plans, consumer-directed plans, not only are the plans save money, but they actually have better health outcomes. And there was a study by McKinsey and Company that said, why is that? People are going to get preventive care more often. They're doing a better job of taking their meds. And somebody said, well, I figured out that if I take better care of myself, I save money in the long run, which is really the kind of incentives that we have to get to. So here's an example of where we've been going over the last decade for the health lab path with health costs. A lot of these different consumer-directed plans have been starting to moderate costs, and now they're starting to go back up because people are saying, well, we've got to comply with all these new federal rules and regulations. So just to conclude, this is what we all agreed we need. We need to make coverage more affordable, make sure we keep quality up, make sure we increase access to coverage. So we need targeted subsidies for the uninsured. I think you're going to start to see a step-by-step approach to common sense reform. Speaker Boehner discusses in a replacement strategy for Obamacare, or really even moving forward, if the law still stands, with other options for consumers. Giving people the same tax breaks if they're getting health insurance on their own as if they get it through the employer. So you level that playing field. I think you'll hear a lot about that. You'll hear more about more functional high-risk tools for people who otherwise would fall through the cracks of the health insurance system. And cutting Medicaid's red tape so states can have more control. And you don't have to have people that fall off the cliff, that fall out of Medicaid because they earn $1 too much. We need to have that be more seamless. And also to make sure that people in Medicaid can actually get access to a physician by being part of private plans. So what does the future hold? I really believe that this global movement toward consumerism is very real. does. And it's because they can get so much information, the Mayo Clinic protocol, Cleveland Clinic. When people want more control over the decisions, we've got to help them have more control over their spending decisions so they can they can impact those decisions. The health overhaul law is in place. It can be repealed. It absolutely will be changed. And it's not over yet. It may be law, but it is not settled policy. Now, I do a lot of Twitter tweets and Facebook, and I do an update 2 or 3 times a week on what's happening in Washington on this law. Free, if you want to send me a note, you can go to galen.org and sign up. You can send me a note at gracemarie@galen.org. Follow me on Twitter, follow me on Facebook. And I have a few things up here for you. I've got a few copies of my book. We do these little things we call pocket cards that are like members of Congress actually asked me, we don't have time to read all these policy papers. Just give it to us. It's something we can put in our pocket, ready-made speeches. So I've got some of these here. And then some of my business cards. And anything you want that's not here. Oh, and I'll find these couple of copies of the chart. So we have a few minutes for questions. Okay, good. Any questions? Somebody need to bring first as a duck. Yes, absolutely. The Service Employees International Union was one of the huge, huge supporters of this law. They're big funders of Families USA, this group that I mentioned earlier. The labor unions they realize now that their best and most affluent workforces are public employees. And they see an opportunity to expand that base of membership by unionizing healthcare workers. And there's actually a new book out by a man named Mallory Factor, who's looked deeply into this and has really found all the memos and the strategy papers in which they really believe that if they can get government control of the healthcare system, then one of those regs yet to be written could say that we believe that the only people that should really be allowed to provide health care to certain segments of the population are unionized workers. California would likely be first. So the nurses unions are really among the first to step up. So how about doctors going on strikes and hospital workers going on strike? I do think it's a very real agenda of people who supported this law is to see potentially several million more people in unions who are organized to provide care for these various new programs. Yes, sir.
With the increase of the folks coming onto this insurance, is there an implied assumption that there's going to have access to? It's one thing to be insured, it's another one to actually see a doctor.
Really good point. The laws, before the Supreme Court's decision making Medicaid optional, the Congressional Budget Office assumed that about 30 million more people would be eligible either for Medicaid or for these new health insurance subsidies through the exchanges. Ed Miller, who was the chief of medicine at Johns Hopkins University, actually wrote an op-ed for the Wall Street Journal just before the law passed, saying, please don't do this to us. We cannot handle the patient populations we have now. If you add 16 million more people to Medicaid in one day, or over a short period of time, it will collapse the system. The people on the program now are not going to be able to find a doctor to see them, and study that worries me a lot about physicians. A physicians organization said that as many as 43% of physicians are seriously considering getting out of the practice of medicine if this law goes into effect, because of all the rules and regulations that they're subject to. And they have the patient's, the value-based payment modifier. I mean, there's just a long list of things that they're going to have to comply with. And they're just saying, well, I can't practice medicine when the government's telling me what to do. I'm just not going to do it. And so I think we have a real perfect storm coming with this millions more people in the healthcare system and doctors leaving. And the doctors who are left are worried that they will basically be told that they don't accept Medicaid patients, then they're not going to be able to they're not going to be able to have Medicare patients, or they're not going to get their licensure from the state. So they're worried about basically having their practices taken over. So it's a very real risk. There's a doctors, in this survey of doctors, and they were very opposed to this law, shall we say. Yes, sir.
I've been an insurance broker specializing in 13 years. And the biggest frustration I've ever had is clients that provide insurance, yet the employee has to pay a little bit. So they decide they're not going to take it. So they're obviously part of the system. So when they do get sick, they go to emergency room and say, I don't have insurance. On the next step, uninsured, that don't pay anything now, even with a subsidy from the government, you'll all of a sudden have to start paying a monthly amount for health insurance. Human nature for me struggles with this because someone who, I call it flat screen TV syndrome. Somebody will spend $100 a month to buy a flat screen TV and buy it, but they will never spend $100 to buy insurance. I just don't feel that there's going to be a lot of these people that are uninsured now that spend, hand them out. Again, all of a sudden start spending $200 extra a month for health insurance.
Well, many people are, obviously, they believe they're going to be eligible for subsidies, but only 19 million of 160 million working Americans are going to be eligible for subsidies. So the great majority of them are going to they're going to have to make these decisions. And of course, with the subsidies, or with the penalties only being $95 the first year, up to $695 for the when it's fully in effect. What they're going to say is, why should I be a schmuck and spend $5,000 a year for health insurance? I'll just pay the penalty, $695. And by the way, the health insurance company has to sell me a policy anyway with guaranteed issue, and they have to sell me at the same rate as if I've been paying all along, community rating. That's why this isn't going to work. The whole concept of insurance is going to collapse because of these rules. And what we should have done is say, why are people not buying health insurance? It costs too much. What can we do to make it more affordable? In California 10 years ago, a young person could buy a policy for $50 a month. You didn't have a big uninsured problem in California. But because of all the rules and regulations and mandates, and now all these community rating, which basically says that the young people are going to have to pay more for their insurance, so older people can pay less to level the premium, even more of an incentive for them to take a walk. So you're absolutely right. I am very worried this is going to collapse the concept of insurance as we know it. Great question. Just
One more thing.
insurance also.
Isn't it correct that the only way that anybody can collect the penalty is if they receive a rebate or a return, but if they owe, they are not allowed, nobody is allowed to put a lien on that portion or add it to the future?
You are so good. Absolutely right. In fact, the IRS is going to have a very difficult time even collecting the $695 because the law says that you can't use liens and foreclosures and all the other penalties they have. All they can do is take, if you've got an income tax refund due at the end of in April, they can take that money to pay for your fine. Well, a lot of young people have said, I could figure that one out. What are they going to do? Yeah. They'll adjust their deductible so they're going to refund.
the same topic, though, it is, how long do you think those numbers are going to take, $95, $6.95 a piece? It just, I mean, that is just an area that's cutting.
Okay?
2,000, 3,000 for a lawyer.
Well, it actually, it's $695 per individual, about $2,000 per family, and then it goes up to 2.5% of income. So the higher your income, the more closer you get to the actual cost of the policy.
Get somebody who's making, or a family making $40,000 a year, I mean, but the draining the system for, hundreds of thousands of dollars a month. There's no telling, right?
Well, except, here you had President Obama with strong majorities in both houses of Congress. That's as far as they could push the penalties. They wanted to get it all the way up to the cost of a policy. They couldn't do it. So that's going to be a political decision. I think it's going to be very difficult to get a Congress that's going to say, oh, good, we all know that 80% of the American people hate this individual mandate, and we're going to increase the size of the penalty because not enough people are buying health insurance. Politically, that's going to be a real tough sell. That's one of the reasons, though, I think this law is going to be in so much trouble. I think we have time for one more question. Yes, sir.
I noticed after it was passed that the president granted about 1,500 or more exemptions to this thing.
Waivers.
And I haven't heard of a recent number, but he's exempted a number of his donors and others
Labor unions.
with large employment legacies. So what's happened with all that?
Well, they were getting so much grief from all the waivers that they were giving that they just put a moratorium on the waivers. We were about to do the Labor Watch, just kind of a website, and, who's the newest person who's gotten a waiver, because we learned that a disproportionate number of them were in Nancy Pelosi's district in San Francisco. A disproportionate number were the labor unions, and it was becoming such a political problem that they just stopped it. But, I think that once we get past the election, if the president's reelected, I think you're going to start to see, that's another thing that's just so disturbing, as about how it doesn't treat everybody alike. If you've got political favors, then you can get a special deal. People hate that. And that's really one of the reasons I think that people didn't like the law in the first place. The Cornhusker kickback, the Louisiana Purchase, the Gatorade, the Yukon, all these special deals the senators had to get to put the law over the finish line. People hated that. And now we're about to say, okay, well, if you have political clout, you can get a waiver and you can get your own special deal. That's not going to work either. So I'll stay up here afterwards if y'all have any more questions, and come see me, and follow us on Facebook and Twitter and